All right, so I think I set this up right, but if you hear a ton of background noise, it's because I have a baby and noise happens, so deal with it. Anyway, psychopharmacology. This was not originally covered in class because it was supposed to be self learning, but I feel like it's a topic that probably deserves a little bit more attention, so we'll go through it quickly, just do a quick review, and then if there's any questions before exam two, feel free to reach out. I'll probably do a review session in class. But anyway, definitely testable, definitely good for clinical. You will likely see it in practice after. So I think what freaks most people out about Psychopharm is not having as much familiarity with the psych medication lineup compared to the more traditional med surge meds. So people usually become insecure about memorizing dosages and things like that. First thing I want to iterate to you is that you don't need to memorize dosages right away. They will, for NCLEX purposes, it's more important that you take the time to learn about things like side effects, know about the neurotransmitters and all that stuff, and then we can focus on individual medications after. They focus more on classes and then specifics about individual meds after, which we'll get into. But ultimately, for psych meds in general, we're thinking about our neurotransmitters, and we're thinking about affecting those neurotransmitters in different ways. That's how we get certain psychotropic effects. And then, of course, when we induce those changes, then clinical manifestations will happen. The key ones to know are going to be, number one, dopamine. That's going to be your psychosis neurotransmitter. Serotonin, your mood neurotransmitter. Norepinephrine, that's your fight or flight. Histamine, which may sound familiar, that is related to your allergies, of course. Antihistamines, Benadryl, things like that. Those will also be kind of the extrapyramidal symptoms that we start to notice are the result of histamine imbalances. GABA, which impacts everything. Glutamate, which is particularly important for alcohol withdrawal. Acetylcholine. They usually don't ask super specific questions on this stuff, but when they do, the key ones that I would say are most important for test purposes are serotonin, dopamine, and histamine. Norepinephrine is important for everything, but for psych purposes, usually they ask questions about the top row of this slide, just for general information. In terms of dopamine, we usually associate dopamine imbalances with thought disorders. Typically, when you think about dopamine, you're thinking about pleasure responses. And then when we have inappropriate levels of dopamine, if they're either too high or too low, we often see that start to manifest as things like schizophrenia, thought disorders, and things like that. It is affected by stress. That is why when people usually have a first break, for example, it is usually triggered by a stress reaction. There's also a genetic component there as well, so they have to have the they have to be predisposed to the psychotic disorder, but also typically when they have a psychotic break, it's the result of a stress reaction that triggers that cascade effect. So dopamine, I want you to think about thought disorders. For serotonin, I want you to think about emotional regulation. Now we're going to start looking at things like depression, things like mania, other psychotic symptoms as well. When you think about medications like SSRIs and antidepressants, those will impact your serotonin levels. We will get into more specifics as we go. Norepinephrine, that is your excitatory fight or flight reaction, things like that. Similar to epinephrine, so we're thinking about adrenaline responses, also stress reactions. Typically, individuals who have PTSD or anxiety disorders often have increased levels of norepinephrine. That is because they constantly have that surge of excitatory chemical in their system. So when they have those physical manifestations, it's the result of that norepinephrine. Histamine, regulatory in general. They are often used, specifically antihistamines like Benadryl, Cogentin, and things like that. They are often used to treat medication side effects. That is the result of extrapyramidal symptoms, which we will talk about when we move forward. But in general, we will see histamines have kind of a renewed level of importance in psychopharm stuff. So something to keep in mind. GABA kind of impacts everything. It affects your sleep. It affects your mood. It affects your anxiety. GABA is responsible for regulating other neurotransmitters. So think of like the overarching balance of your neuroreceptors. When we think about GABA, we're thinking about one chemical kind of helping to regulate all of the other ones that are in your system. So if that's out of whack, we'll start to see kind of everything start to change a little bit. So that's where we start seeing mood. We start seeing psychotic symptoms and things like that, disruptions with sleep, all that stuff. Then we have glutamate. Like I said, this one is key for alcohol detox. We usually see an increase in glutamate when individuals are going through alcohol detox. And as the result of it being an excitatory neurotransmitter, when people are detoxing, we will start to see their increase in things like blood pressure, pulse rate, which puts them at risk for more issues that might occur, and which is why alcohol detox is considered to be potentially deadly, and we need to take it very seriously. This is just part of that process where things start to elevate, and when things elevate, we start to worry about things shutting down. So heart attacks, strokes, things like that all kind of plays into effect here. Basic slide on neuroplasticity. The brain naturally will, in the presence of some kind of change in the system, will naturally form new neural pathways. When you think about learning, for example, when they say like, oh, when you're younger, you learn better, it's because you have increased neuroplasticity when you are younger. And as you get older, it tends to become a little bit different. It becomes more difficult to learn new skills. That's why they say you can't teach an old dog new tricks. Neuroplasticity is kind of that concept for nursing purposes. When we think about things like antidepressants, for example, when we're like, hey, why doesn't an antidepressant work in the first dose? It's because when your brain is forming those new neural pathways to help balance your serotonin levels and things like that, that takes days, weeks, months, even years sometimes. So when we start thinking about forming new neural pathways that improve the brain chemistry, it's usually something that takes a while, so we don't always see an impact of a medication right away. The key impact of this slide that I want you to take away is that medications for psych purposes don't always work on the first dose. They usually take a while to build up in the system to help the brain adjust to new neural pathways and form those new neural pathways to better serve what needs to be done for the brain, basically. So if we're having serotonin imbalances, for example, and we use an SSRI, which is preventing the reuptake of serotonin, the brain needs to adjust and form new neural pathways in order to adjust to that brain chemistry change. So that's where neuroplasticity comes in. Basics, balancing. It's ultimately achieving homeostasis. Mental illness manifestations are the relation to imbalance of neurotransmitters. Nothing too crazy. Don't get too bogged down in the weeds with this. What I do want you to take away is we are trying to achieve balance in the brain chemistry with our antipsychotic medications and other psychotropic medications. For that to occur, usually there needs to be some kind of neural pathway change, which as a result of taking these meds, there are often significant side effects, which we will talk about when we get into the individual meds. So in general, what I want you to do is, number one, learn the drug classes. Just like any other type of pharmacology, it's much easier if you understand the general overarching topics for each type of drug. So learn about the common details of those drugs, what they are used for, what typical side effects are, and then learn how those drugs are named. So we really want to focus on being able to identify meds. If you were given a random NCLEX question that focused on some kind of antipsychotic medication and you just didn't recognize the med, but you knew, all right, I know that it ends in DONE, therefore it's probably an antipsychotic, you are likely to have a better chance of answering that question correctly if you at least are able to identify the medication. Most psychotropic medications, if they are in a specific class, will have a specific nomenclature. There are some unique ones So those are usually the ones I recommend memorizing just for the sake of having it in your brain. But for the most part, if you learn the class and learn the nomenclature, you can get 80 to 85% of the questions and figure out what the meds are based on that information. After you do that, then you can start focusing on individual drugs, specifically ones that either have a therapeutic level, so anything that requires a lab draw to see what the levels are in the blood, and anything with a special characteristic like a unique side effect. A lot of medications that are tested on for analytics purposes are those unique drugs. And there aren't that many of them, so it isn't super difficult to memorize them. I'll identify the ones that are usually most important. And then once you're done with that process, learn about how the drugs are used together. So if we're going to prescribe, for example, an antipsychotic, what kind of drugs do we want to use in conjunction with that medication in order to either prevent side effects or ensure the medication is working correctly and things like that. So for the purpose of learning psych meds, I want you to follow this process. Makes things just a little bit easier for you so that you, when you're studying, you don't have to just brute force memorize a giant list of medications. And with that, we'll go over the individual medication groups with specifics. So I would say this is going to be the bulk of what you should be studying for your Psychopharm test questions. Definitely testable. Pay attention. And I always say make flashcards for this stuff just because it makes it a little bit easier. Again, drug classes, learn the naming conventions, study any specific meds, and then drug relationships. Like I said, have this process down. Makes your life easier. We're going to cover 5 drug categories. Antidepressants, number 1. Then we're going to cover antipsychotic medications, anxiolytics, mood stabilizers, stimulants. For antidepressants, we're going to be focusing on the process of beginning those meds, tapering them down, and then specific side effects, things to look for, things that are commonly testable. Antipsychotics will focus on primarily the side effects and how they are used. Anxiolytics, mood stabilizers, you get the point. For antidepressants, designed to make you not depressed, obviously, they will affect your mood. There are specific antidepressant classes that I want you to memorize. The most common ones are going to be your SSRIs, your selective serotonin reuptake inhibitors. Those are designed to prevent the reuptake of serotonin into your system. So when you think about your brain and your synapses, you have serotonin in the gaps between your neurons. That is what is usable to the brain. When you are having reuptake, your brain is reabsorbing that free serotonin back into your nerve cells, ultimately in your brain cells. If there is not any free serotonin, or if you have a reduction in free serotonin, what typically happens is your brain doesn't have as much serotonin to work with, and so that's where you start seeing depression symptoms form. So what SSRIs do is they prevent the reuptake, so they are not reabsorbed and there's more free serotonin in the brain. SNRIs work similarly, but they also impact your norepinephrine. Then we have our tricyclics and our MAOIs. I include those because they have specific case uses, and they also have specific needs that you need to know for testing purposes. Most common are SSRIs. Then if an SSRI is not as effective, they will often transition to an SNRI or a tricyclic, and then MAOIs, which have the worst side effects and the most specific needs. Those are usually the last line before they try something else like ECT, for example. For testing purposes, when your patient starts an SSRI or any other antidepressant, they will be at increased risk for suicidal ideation and suicide attempts. Therefore, your safety is your top priority. You will 1000% get a question on this. Typically, it relates to the patient's presentation when they start taking an antidepressant. If suddenly they have a change in their affect, for example, and they're suddenly much, much happier and they're giving their stuff away and they're feeling great, that is now a red flag. This person may be considering suicide. Typically, people who are suicidal, when they start taking a medication, what happens is they gain the energy that they didn't have before, and that's what allows them to move forward with their plan. So number one, consider suicidal ideation. If your patient is showing those red flags, go ahead and do a suicidal assessment, and then consider a one-to-one if they are at high risk. They do take a long time to start working. Typically 3 to 4 weeks is what is suggested, but they can take up to 6 to 8 weeks for a therapeutic effect to take hold. Patients will complain that they don't notice an effect right away. That is to be expected. If the patient is saying that they are not noticing any changes and they're still feeling their depression symptoms, that is normal. We want to encourage them to keep taking their medication. If they stop cold turkey, they can be at risk for a bunch of different adverse effects. So we want to make sure that our patients are compliant with their medications. Typical side effects, the one that people most often complain about is weight change. People do often gain weight when they start antidepressants. There is also sexual dysfunction. People either report erectile dysfunction, inability to achieve orgasm, and things like that. Mood changes, cholinergic effects. All of these will relate to poor compliance. So if a patient feels like they are struggling as a result of their side effects of their medication, they are likely to stop taking it. So we want to encourage them to continue, because as the medication achieves therapeutic effect, those side effects will decrease typically, or they can usually provide additional medication or some kind of therapeutic intervention to assist with those changes. Again, don't let them suddenly stop taking the medication. If they stop taking it, that will lead to a bunch of different adverse effects. We're thinking about serotonin syndrome. We're thinking about weaning disorders and things like that, where the body does not react well. So we do not want people to quit cold turkey on their antidepressant medications. For testing purposes, unique characteristics. Every single one of these will be a test question, I guarantee you. SSRIs and SNRIs, they put you at risk for serotonin syndrome. If you are taking too much of an SSRI, or if you cause some kind of disruption to the serotonin balance in your body, serotonin syndrome can occur. This can often happen when people are either increasing their dose, starting a medication for the first time, or they're transitioning between meds and they're taking both, which is typically not suggested because of the risk for serotonin syndrome. We will talk about that moving forward. Tricyclics, they typically put you at higher risk for orthostatic hypotension. So we're thinking about potential for fall risk. Then the big one, MAOIs, you have to eliminate the intake of tyramine. Tyramine occurs in aged foods, things like cheeses, alcohols, cured meats, things like that. If you are taking an MAOI, you cannot have any intake of tyramine because that will lead to adverse effects. I very rarely see MAOIs used. They are used intermittently for people who try every other type of medication and they don't work. But they're often not used because, number one, it's a pretty significant restriction to be like, you can't eat anything with tyramine in it, because that eliminates a pretty big chunk of most people's diets. So that does kind of pop up because it's so unique and so specific that the NCLEX just loves to ask questions on it. So keep it in mind. Serotonin syndrome, again, increase in serotonin. And like I said, with taking multiple antidepressants, they usually try to avoid doing that because it puts you at risk for serotonin syndrome. Also, specifically another NCLEX topic, St. John's wort, which impacts every psych medication known to man. Taking antidepressant with St. John's wort puts you at increased risk for serotonin syndrome. The reason why we care is because you can die from serotonin syndrome. We usually see increased heart rate and blood pressure. We see restlessness. Muscle rigidity is another big one, which we'll see pop up more and more as we go through these slides. So when we have too much serotonin in our system and the brain doesn't really know what to do with it, it's going to keep using it, obviously, because we have that negative feedback loop. So if our patient presents and like, hey, I feel really restless, my heart rate is elevated, my blood pressure is going up, I have a headache, we're going to think about serotonin syndrome. We're going to think about keeping a closer eye on that patient because, like I said, there is a risk for permanent injury or death as a result of those increases. So we do want to take it seriously. Antipsychotics, obviously designed to make you not psychotic. I hope that is obvious to everybody. We're going to break it down into two major classes. We have our first generation antipsychotics and our second generation antipsychotics. You'll also hear them called typical and atypical antipsychotics. In general, for study purposes, this is a significant generalization, but first generations typically tend to be the older meds, and they also tend to focus on those positive symptoms, which we covered when we covered thought disorders. So when you think about positive symptoms, we're thinking about things that add to your reality, so hallucinations, delusions, and things like that. First generation antipsychotics also typically have a much wider side effect group, so we usually see more severe side effects with the first generation antipsychotics, but they do tend to be quite effective. Second generation are the newer ones. They tend to focus on negative symptoms as well, while also addressing those positive symptoms. When individuals start taking antipsychotics for the first time, they are typically started on a second generation antipsychotic, and there are a few that we'll look into further. And then as we kind of work on their treatment plan and see how they do on those medications, we may or may not add a first generation as a PRN or as a primary medication just to help the patient adjust to those side effects. For major class characteristics, they all have pretty significant side effects, and they do tend to be quite sedating. Antipsychotics are often used in restraints because they help the patient go to sleep. But patients usually report feeling foggy. They report that they don't feel like themselves. As a result, poor compliance is a significant issue. So they say, you know what, it's just not worth it. I'd rather be psychotic. So they start taking themselves off their psychotic meds, which obviously will lead to relapse in their symptoms. And then they end up having that cycle of going to the hospital, get back on their meds, they feel better, they leave the hospital, start having their side effects, so they take themselves off the meds, they become psychotic again, and they go through that cycle of break, treatment, break again, treatment. You see the point. For specific medications, number one, your long-acting injectables. Those are also called depot shots or depot shots. They usually will last for 1 to 3 months of coverage. A couple different antipsychotic medications have long-acting injectable versions. I'm not going to test you on them specifically, but just keep in mind that they do tend to have a coverage of 1 to 3 months. There are some that have 6 months of coverage now. Insurance companies don't always cover them, so when they become a treatment option, it's important that patients understand if they are able to continue using them or not. Once they start taking them, if they're able to be stabilized on it, they don't necessarily need to take an oral medication, but in some cases they do, depending on how effective the long-acting injectable is. But when they take them, they usually have a lower side effect window because it's more consistently in their system. So long-acting injectables are a great option for a lot of people if it's feasible for them and they have access to be able to get their injections routinely. Next one's going to be clozapine or Clozaril, which is a typical antipsychotic and a very strong one. The issue with clozapine or Clozaril is that it can decrease your white blood cells. You'll see them use the term agranulocytosis, which can occur with any antipsychotic, but it's most common with clozapine. So patients who are on clozapine typically have to get routine blood draws. When they start their treatment, they usually have to get them every couple days. And then as they build up, they might be able to do it every week, every 2 weeks, etc. But they're at risk for increased infection. So typically, if you are to get a question about clozapine, it's usually a patient presents with a sore throat and other signs of illness. What's your primary concern? Obviously, it's going to be they're taking a med that puts them at increased risk, so they're at increased risk for infection. Good slides to memorize for test purposes. Mood stabilizers, very fun. Usually we see mood stabilizers split up into either anticonvulsants or just general mood stabilizers. They do get their own category. But a lot of medications, for example, gabapentin, are used for mood stabilizers because they have secondary uses and they impact your brain chemistry in similar ways. So it is often used in that case as well. So as we get into them, Most common, the biggest issue people are going to run into is weight gain. Um, I've had patients gain 30 pounds during an inpatient admission because they started an mood stabilizer. It can be, what it basically does is it increases your desire to eat even if you're not hungry. So patients usually become quite ravenous when they start a mood stabilizer. The biggest culprit is usually Depakote. People who start Depakote for the first time will often experience just severe hunger and they'll want to eat all the time, which puts them at increased risk for things like diabetes and stuff like that. Mood stabilizers usually have therapeutic ranges. The big ones are going to be lithium, which is going to have its own slide, I guarantee you. Depakote and Tegretol, which is an anticonvulsant. Again, as a result, patients tend to have non-compliance. Also, patients sometimes like having those hypomania or mania symptoms, so it is a common characteristic that patients will stop taking their mood stabilizers just because they like having the extra energy, and they also want to lose weight. So obviously something to consider there. They do take time to reach their therapeutic levels. So when people are starting lithium, for example, they will have their labs drawn routinely. We are worried about toxicity. So we do want to monitor them quite closely. So often when people start these medications, they do so on the inpatient level. And then we usually keep them for a little bit longer just so we can make sure that they are stable before they leave. Because we don't want to have them coming back and forth, getting lab draws, and then being at risk for non-compliance when we can get them tapered up effectively on the inpatient level. Lithium is super duper popular on the NCLEX. The reason why is because it has a narrow therapeutic window. So when we think about our lab values, typically it is 0.6 to 1.2. And there's a whole trajectory of symptoms where as they're building up and they're subtherapeutic, they might be showing signs of toxicity. We want to make sure that we're continuing to provide that medication to get them to a therapeutic level. If the patient stops taking their medication and we don't know how long they've been off the medication for, we usually restart the regimen from scratch. So we'll make sure that it gets out of their system completely. And then we'll start them again from scratch, get them built back up on the medication, get their levels to a therapeutic range. If they are too high and their lithium level is elevated, that can lead to kidney damage. We've had patients go from having no kidney issues to having end-stage renal disease as a result of lithium. So compliance is super important and close monitoring is very important. Obviously, if your lithium is too high, you're causing all kinds of bodily damage. You're also at increased risk for seizures. So a lot of things can happen, which is why lithium is very heavily covered on the NCLEX. Just something to keep in mind. Anxiolytics. For the sake of easiness, differentiate between benzos and non-benzos. Benzos are addictive. They typically are quite effective, but there is that risk for things like sedation, things like addiction, stuff like that. So in a lot of cases, what they will do is they'll start people on non-benzos, and if they feel like they need to be elevated to a benzodiazepine, they'll make that decision with their provider. Benzos are controlled, so when you're pulling a med in clinical and happens to be a benzodiazepine, you are going to have to count it because they carefully track them for the risk for abuse. Highly addictive. They work on the same neural pathways as alcohol does, so individuals who take benzodiazepines often demonstrate similar symptoms to someone who is intoxicated on alcohol. It will appear in a urine tox screen, so if someone is applying for a job, for example, or they're in the job hunting process, it's something to educate your patient on if they haven't taken a benzo before. Can be very sedating, so a question I see very commonly is, oh, your patient's going to drive a car and they're starting a benzo. What should you do? Stuff like that, where it's like, don't operate heavy machinery until you know how it will react with your body. In general, don't take a benzo and then drive a car. If you're taking a benzodiazepine for a long time, it builds up in your system, you develop a tolerance. And as a result, if you stop it abruptly, you will detox similarly to how someone from alcohol would detox. It can be deadly. It will lead to increased blood pressure, increased pulse, all of that excitatory reaction from the brain can cause a deadly reaction. So we want to detox people carefully when they are on a benzo and they want to come off of it. People who are going to halfway houses, for example, or any kind of substance treatment facility, they often don't allow benzodiazepines. So people who come inpatient to come off their benzos do so they can detox safely so they can go to their programs. Common non-benzos, we often see Benadryl and things like Visceral or hydroxyzine. They are usually used just for their kind of, quote, take the edge off approach, something that can make you feel a little bit sleepier, a little bit calmer. For people who have those more physical blood pressure type reactions, propranolol is very common. We also see Boost Bar. We'll see some certain antipsychotics used, especially at night because they are sedating. Seroquel is often used in the elderly population because it helps them sleep at night, especially if they have agitation or sundowning. Haldol as well, but typically Seroquel is more common, I would argue. Haldol tends to have a wider range of side effects. And then for our stimulants, usually we see these initiated with the younger childhood or adolescent population for things like ADHD or depression. Individuals who take stimulants usually do so to increase their energy and their CNS stimulation, things like that. Patients who take stimulants often have weight loss. They don't feel as inclined to eat and they're constantly go, go, go. So they're burning a lot of calories. Can also see an increased agitation. I would argue, based on my own personal practice, that individuals who are coming off of a stimulant tend to have a lot of agitation and tend to have quite difficult detoxes just because they are going to miss that medication, obviously. But for things like ADHD, especially in the younger population, these will help individuals be able to focus on whatever task they're doing. Usually it helps with their school performance and things like that. So they are helpful in that regard. And that's pretty much it. So when you are studying, I will supply you with a list of the medications that I recommend taking a look at. That is currently posted in Blackboard. So take a look at that. And if you have any questions, reach out to me. Hopefully this was quick. I don't think it's been running that long. Good. All right. Have a good day.